Hello, thank you for tuning into this video program. I'm Mr. Manohar Jesuraj, consultant urological surgeon based at Best Life Clinic in the northeast of England. We are privileged to work with a team of nurses and other colleagues to provide best possible and a synchronized care to the patients who come to our clinic seeking to have advanced microsurgical treatments for scrotal conditions, as well as to have advanced vasectomy reversal. We take pride in providing the best possible vasectomy reversal in the UK, and our clients and patients coming from all corners of the United Kingdom, as well as other European countries, Republic of Ireland, and also further afield as far as Canada and the United States, and eastwards all the way up to Dubai and Singapore. So we are in a uniquely privileged situation to offer this service. And I'm going to go through a short presentation, which is usually the presentation I would give to those patients who would consult me remotely, so that you can make an informed decision whether you would like to avail our services to have the vasectomy reversal. Men seek to have vasectomy reversal for a number of reasons. The most common reason is to regain the fertility and restore their ability to father another child. Presume most men have the vasectomy after having fathered a child, but occasionally men do have vasectomy even without having fathered a child before. So most of the men want to regain their fertility. That's a common cause of requesting a vasectomy reversal. When they make a decision to have a vasectomy, they believe that's the right time for them. They believe their family is complete, or they don't want to have any further children. But things do change. Sometimes when couple together have children, and when the children grow, and they may want to have another child. And more common cause for the requesting a reversal is the breakdown of the relationship, and they meet a new partner, and they may want to have a family together. And occasionally men do come to have vasectomy reversal just for the sake of regaining the sense of returning back to normal. It is a difficult thing to define for me as a surgeon, but however, we do offer the services of vasectomy reversal, clearly explaining as far as the surgery is concerned, the reversal is just to reconnect the tube, and men are happy with that. And a small subgroup of men require vasectomy reversal and certain other operations as relevant for the post-vasectomy pain. In this talk, I would particularly concentrate on the vasectomy reversal for regaining the fertility. In our service, we provide the vasectomy reversal in a multi-layer technique. Prior to that, I will briefly explain to you about the anatomy of the scrotum. As you could see in this slide, both testicles produce sperms. The sperms come to the top internal part of the testis called rete testis. From there, it is picked up by a long coiled tube called epididymis. The epididymis is a structure that contains a long coiled tube that is about 20 feet or 6 meters long, that is condensed into the structure, which is only 2 inch or 5 centimeter long. And as the sperms goes through this highly coiled system of tubes, they mature and gain their ability to swim. As they come out through the tail of the epididymis, that continues as vas. The starting part of the vas is called convoluted vas, which contains a thin wall, but at the same time a bit broader in canal or lumen. That means it's more capacious, or that has got a slightly higher capacity to store sperms. This is the place where the sperms will be stored. And the rest of the vas is straight, that contains a thick muscular layer and a very thin internal lining, and the outer fluffy layer that carries the nerves and the other supporting tissues. During ejaculation, the coiled part of the convoluted vas contracts and pushes the sperm up. And the sperm goes all the way up to the vas. Vas goes into the side wall of the groin and goes behind the bladder and joins the other glands called prostate and seminal vesicle. From there, the ducts from those glands join these vas, and the semen containing the sperms are deposited in the top of the penis into the urethra. From there, it gets ejaculated during ejaculation. So this is the long course of the sperms from the testicle all the way outside, carried by this structure called vas. Vasectomy disconnects the vas at the scrotum. because that's the only place where the vas is easily felt. Even though the vas is about 30 centimeter long, it's usually felt in the scrotum, and the surgeons cut the vas. It is cut on both sides to make a man sterile, and there is no regulation or where the vas will be cut. The surgeons will cut the vas wherever it's easy to feel. And they may cut it or cauterize the ends, or they may take a segment of it. Sometimes they take even as much as 1 or 2 inches to make the reversal much more difficult. So no two reversals operations would be the same. Even in the same person, both sides can be very different. So the reversal is a highly complex procedure. The surgeon should be very experienced and capable of dealing with multiple variations that we would encounter and the difficulties we would encounter. It could be due to the vasectomy itself, or it could be due to the thinness or the diameter of the vas, or the degree of damage caused by the vasectomy. So the multiple factors can pose challenges during the reversal. That's where the advanced microsurgical technique is important. We do this vasectomy reversal in a multi-layer technique. I will explain to you the next few slides. So my approach would be through a horizontal cut at the top of the scrotum, and to identify the cut ends of the vas and trim those ends and prepare those cross-section and connect it in 3 layers. As I told you, vas contains 3 layers. We prepare the vas by trimming the vas in a very short trimmings of less than 0.5 millimeter at a time, so that we could have a very healthy cross-section. So the aim is to remove any kind of scarred areas or any abnormal swellings called granuloma at the end of the vas. And we will connect the innermost layer, as you could see in the slide, with the extremely thin stitches called 10-0 nylon stitches. The stitch is much thinner than a hair. The needle attached to the stitch is only 100 micron diameter. That means it's slightly thicker than the hair. So such an amount of minute stitches are necessary to align the inner canals of the vas, or inner lumens of the vas. As you could see in this picture, this compares how we do the multi-layer technique, and most other places they do the single-layer technique. The multi-layer technique aligns the inner canal as best as possible. So that is the beauty of the multi-layer technique. Sometimes the inner canals of both ends may not be of same diameter or same size. The inner canal is only between 0.2 and 0.5 millimeter diameter. It's thinner than the tip of a fine-tip ballpoint pen. And the both ends can have very different diameter. The end attached to the testicle can be very bloated and wide. The other end can be very thin. So in the inner layer, when the inner layer is connected separately, the inner lumen or canal is aligned perfectly, as you could see in this picture. The other 2 layers make it leak proof. And the leakage and malalignment, they are the common cause of scarring and failure after the vasectomy reversal. As you could see in the picture on the top of the slide, where the single layer technique, it may align the overall vas okay, but the inner canal is not aligned perfectly. So the multi-layer technique aims to align the inner canal as best as humanly possible, to make sure, or to give the best possible chance of the joint remaining open or patent, so that the sperms can pass through without any restriction. So we will do the vas to vas connection when we find some sperms at the cut ends of the vas. Once we approach the vas, we will take the fluid from the end of the vas attached to the testicle, examine on the microscope, and we will make a decision based on. So we perform the multi-layer vas to vas connection called vasectomy when there is evidence of sperms present at the site of cut of the vasectomy. We want to make sure the sperms are making their way through the epididymis to all the way up to the end of the vas. For every passing year since vasectomy, there is 2% chance of damage occurring in the epididymis. I told you the epididymis is a highly coiled microtube. The tubes within the epididymis only 0.5 millimeter diameter. And during ejaculation, the end of the vas contracts, and therefore the tail end of the epididymis can get damaged by pressure. So the chance of that is 2% per year since vasectomy. There is a damage and there is a blockage. There is no point in connecting the vas to the vas. However wonderful we could achieve that connection, it won't work. Therefore, if there is a sperms at the end of the vas that is attached to the testicle, and if there's a good flow of fluid, and if the fluid looks thin and clear or cloudy, and that indicates the epididymis is likely to open. In that situation, we will do the vas-to-vas connection. In these slides, you could see how we do that microscopically. You could see some of the real-life pictures through the microscope. You could see the inner layer is connected first. We connect the back end of the inner layer first, and you could see the perfect alignment of the inner canal of the tube. That canal, what you see in this video or in this photograph, is extremely thin. It won't even accommodate the tip of a fine tip ballpoint pen or a minute cannula. So that's where the magnification of the operating microscope is important. Many surgeons do it with the magnifying loops, which could hardly give a magnification of about 4 times at its best. But the operating microscope gives the opportunity to give the magnification up to 20 times. So my usual operating magnification during this part of the procedure is between 12 and 15 times. So that helps to align the minute inner canal. In the event of a blockage to the epididymis, we will do a bypass operation called vasoepididymostomy. In this slide, you would see the vas is brought close to the epididymis, and we will isolate a minute tubule or microtube within the epididymis. That tubule is much more flimsy and thin. You cannot really have a cut end and connect to the thick vas. Therefore, what we do, we will isolate a single loop of that coils of tube and make a microcut, and we will examine the fluid from that epididymis tubule under the microscope, and if it shows sperms, we will do an advanced connection called interception end-to-side vasoepididymostomy. That means connecting the side of the coil of the tube to the end of the vas by using an advanced technique. And we do that routinely. 1 in 5 men who come to me for vasectomy reversal end up having a bypass operation at least on one side. Therefore, a vasectomy reversal service cannot be a complete service if the surgeon or the clinic does not have resources or technical expertise to perform the vasoepididymostomy. And we will not know that only except at the time of the operation. So it is important to check the fluid from the vas under the microscope, which is not performed in most clinics. And based on that, we'll make a decision about what operation to do, either vas to vas connection or vas to epididymis connection on each side. The decision can be very different from one side to another. Most men will have a vas to vas connection. Some will have a vas to vas on one side and vas to epididymis on the other side, and very few will have vas to epididymis on both sides. So the time since vasectomy is the usual determinant about the chance of having a blockage at the epididymis. So this is about the operation. Now, what to expect if you choose to come to us for a vasectomy reversal? So we do the vasectomy reversal under local anesthetic. You may feel a bit puzzled or anxious to hear that you'll be awake during the operation. Trust me, I have done 650 men this operation. Not even a single time we have failed in completing the procedure which we needed to do just because of anesthetic. We have seen men of all anxiety profiles, extremely cool to extremely nervous, and every man walked through the procedure well and happily at the end of the procedure. The operation is painless, except the few pricks you will feel in the beginning. You will not feel any pain after that. And the pain score recorded at the time of the operation in our audit is 2 out of 10 at its worst, only in 20% of the patients. And that's at the beginning of the procedure during the initial pricks and the start. So when you come to the clinic, you will be received by our reception staff and the nursing staff. Then I will see you personally and I will examine you and apply some local anesthetic cream in the scrotal skin. And over the next 20 to 30 minutes, the nurses will come and see you and give you some pre-medication, and we'll take you to the operating room. And we will inject some local anesthetic at the skin. It will completely numb the skin, and further injections you will not feel, and probably you won't feel more than 90% of the pricks that we will use at the time of the operation. So during the procedure, we will first prepare the tubes, then we will go through the microscopic part of the procedure, which could take about 2 to 2.5 hours. And at the end, then we will completely close the wound and leave a bandage in the scrotum. So overall time in the operating theatre could be around 3 hours, sometimes a bit longer, if we have any difficulties during the procedure, particularly with the reversals and if there are any challenges in the vas. What about the recovery? We will advise you to be in absolute rest for the first 5 days. Just spot along within the house, don't do any walking outside, and take absolute rest as much as possible. And except you have to walk within the house, take rest. That will help to avoid any complications of bleeding into the scrotum. Common problems after any scrotal surgery is the scrotal hematoma. That means bleeding into the scrotum. If we could avoid that for the first 48 to 72 hours, that will make the recovery smoother. Even though we say there is a risk of 1% risk of significant hematoma or abscess formation or due to infection requiring further surgical interventions, I'm pleased to inform that we did not have any return back to theatre for dealing with the complication in last more than 600 patients. In the second week, normally you can return back to office-based activities. The third week, you can return back to manually active activities. We generally recommend to refrain from sex or ejaculation for 3 weeks. I know some clinics offer 2 weeks, some clinic advise 4 weeks. I think 3 weeks is an optimal period. We would advise to completely refrain from any gym activities or any contact sports or anything that would pressure on the scrotum, such as anything with saddling position, such as bicycling or horse riding, to be avoided for 6 weeks. The scrotum will be lumpy, not necessarily painful. It will be lumpy and hard for several weeks, anywhere from 3 weeks to 3 months. So that should not bother you. As long as there is no increasing redness or increasing swelling or increasing pain, there is no cause for concern. So that's about the extended recovery time. As you know, with any operation, there will be occasional twinges of discomfort, particularly when you get more and more active in the week 2 or 3, or when you go back to your normal activities. Simple things like getting in and out of the car then can squeeze the scrotum and cause a bit of pain. So that's normal. As long as there's no increase in the swelling or pain or redness, there's no cause for concern. Generally, the scrotums return back to normal over a period of 3 months, and occasional twinges of discomfort may be there for several months that usually settle down. So that's about the recovery period. So how do we measure the outcome of the vasectomy reversal? I know you are interested in this vasectomy reversal operation to achieve a parenthood. That's a dream. As a surgeon doing a vasectomy reversal, I can only assure the outcome of patency. That means after the operation, there are sperms in the semen. So that's a measure of outcome as far as the operation is concerned. Of course, it'll take you one step to the parenthood, but there are many other factors that will be involved in achieving a pregnancy and a childbirth. So the patency after vasectomy reversal depends on a number of factors. The most common one is based on the time since vasectomy, also the reversal operation technique and the surgeon's expertise. Of course, we can assure on the expertise and the best possible microsurgical technique, but the time since operation is not a controllable variable. Therefore, men who had vasectomy less than 10 years ago, our success rates are more than 80%. Men who had vasectomy less than 5 years, our success rates in achieving a patency is more than 90%. Our cohort of overall success rates of more than 600 patients from 1 year since vasectomy to 25 years since vasectomy, our success rates is around 84%. Of course, the longer the time since vasectomy, if it is more than 20 years, the overall success rates will drop down below 50%. The other factors at the time of the operation we will encounter also will give an indication about the chance of success. The vas which are thinner than 2 millimeter in diameter tends to block more often, and fail after the vasectomy reversal. Therefore, we will advise to do the sperm banking so that you have some backup option if the joint at the site of the reversal blocks. So that's an important thing to consider after the vasectomy reversal. The other compromising factor for the success is the presence of blowout or blockage at the epididymis. So if you have to do a bypass on both sides, the success rate can drop down to 40 to 50%. Still, we have seen pregnancies in men who had bypass on both sides for blowout on both sides, who had vasoepididymostomy on both sides, still managed to achieve pregnancy and childbirth, but the chance of success will be less. So the best possible outcome will be with vasovasostomy. However, if the vasovasostomy is not appropriate, we should be capable of doing vasoepididymostomy. So that we offer routinely. I hope this helps you to make a decision whether you would like to choose the vasectomy reversal or the alternative option of IVF. The choice is difficult. Both choices do not offer any guarantee of total success in achieving parenthood. And also options are expensive because these treatments, either IVF or vasectomy reversal, is not mostly available in the NHS. I leave it to you to decide based on the information I have given you in this video. And if you would like to avail our services, please feel free to book a video consultation by clicking the link below, and I'll be more than happy to give further information. Of course, it will be for a fee, and we will be in touch with you to arrange the consultation at our earliest convenience. Thank you for your attention.